consider tissue healing and repair. From this lecture, hopefully by the end of the session, you should be able to describe the key stages of the tissue healing process and also demonstrate an understanding of how the pathophysiological processes relate to the typical signs and symptoms of inflammation that we will see within our patients. The tissue healing process is fundamental to all of the patients that we see, the many pathologies and injuries that we come across within our patients. We treat them because their tissues are damaged, so we need to understand the processes that are taking place so that we know what we can do and when with our treatment modalities. If we look at a definition of inflammation, it is in fact a homeostatic process. Inflammation is the immune system's response to tissue damage, which aims to repair tissue and bring it back to its original state. So it's a physiological defense mechanism at the site of the injury in an attempt to heal the area. So it's a natural process that is trying to return the body to normal. When we talk about tissue healing, we can consider 4 phases. We have the bleeding stage, the inflammatory stage, also known as acute inflammatory stage, repair or the proliferative stage, and then the remodeling stage. Although we list these as different stages, it's important to recognise that they don't take place in a linear process. So looking at this graphic by Watson from 2004 explains that quite nicely. You can see how all the different stages may well overlap, and this will depend on a number of factors. If we think about the timing of the different tissues and what the normal timings might be, it gives us some indication as to what we can do with our patients and when. But it's important that we recognise what the signs and symptoms are that relate to these different stages so that we can recognise within our patients what stage they're at and how we can treat them. So, for example, the bleeding stage is short-lived. It varies according to the vascularity of the tissue. So if we've got a muscle with high vascularity, that will bleed much more than a ligament, which has much lower vascularity. So that can vary between 6 and 24 hours. The inflammatory phase has a rapid onset, usually within a few hours, tends to have its maximum reaction at 2 to 3 days and then gradually resolves. Remember that it can go on up to a few weeks though, so be prepared for that, watch out for that. The proliferative phase usually starts around 24 to 48 hours and tends to reach its peak at 2 to 3 weeks post-injury. That's when the bulk of the scar tissue is formed but not yet complete. And then the scarring gradually decreases from this time onwards. Remodelling is an essential component of tissue repair and probably starts at 1 to 2 weeks. In order to understand what happens in tissue healing, you need to have an understanding of the normal capillary filtration and reabsorption process. What I want you to do now is pause the lecture and watch this link on YouTube just to remind you of that process. So when we think about filtration and reabsorption, we have the blood hydrostatic pressure that forces the fluid containing water, oxygen and nutrients out of the capillary through the small fenestrations within the blood vessel wall. The plasma proteins cannot pass through these under normal circumstances, so therefore we have an osmotic pressure that's created by the plasma protein, which draws the fluid, the water, the carbon dioxide and the waste products of the cellular activity back into the capillaries. At the arterial end of the capillary, the blood hydrostatic pressure is greater than the osmotic pressure, therefore that's where filtration takes place. The blood hydrostatic pressure drops off as we go across the capillary, and therefore at the venous end of the capillary the osmotic pressure is greater than the blood hydrostatic pressure, so therefore that's where reabsorption takes place. So if you think about what happens, we'll have 9/10 of the fluid leaving and re-entering through this filtration and reabsorption process. So 1/10 of the fluid will return to the bloodstream via the lymphatic system. If you have a look at this link on the slide, it'll explain this in more detail. So in acute inflammation, we have a series of vascular events and cellular events. Again, it's not a linear process. These events are taking place simultaneously, but we'll look at them as individual events. With the vascular events then, first of all, we have vasoconstriction. So this is a short-lived event which is followed immediately by vasodilatation. The vasodilatation process is produced by the chemical mediators that are produced by the tissue damage. What follows on from this is increased capillary permeability. So we get retraction of the endothelial cells in the walls of the capillaries, and that causes larger intercellular gaps, which allows the plasma proteins and cells to escape. What also happens with this increased capillary permeability is that it allows the appropriate cells and chemicals to move to the area of damage to assist in the inflammatory process. So in inflammation, the removal of the proteins as well as the fluid at the arterial end means that the osmotic pressure isn't increased as much as normal, so that the driving force for the reabsorption of fluid isn't generated. So the fluid therefore remains within the tissue. So this is why we have excessive tissue fluid. Remember that that exudate, as we call it, will be drained by the lymphatic system, but because of these differences in pressures, it will be replaced by new exudate. Moving on now then to the cellular events, we can describe them as margination, emigration and chemotaxis. So margination is the process whereby the granulocytes become closer to the cell wall and adhere to the endothelium. As they become fixed to the endothelium, they produce pseudopodia, which allows them to pass through the wall of the endothelium. We then also have the process of chemotaxis, where we have the chemical mediators sending out signals which attract the phagocytes to the target area. Within this inflammatory phase, we have a preparation for the healing phase. So we get the clot forming in the area with a fibrin lattice work. So we have a mixture of the cellular exudate and debris that has escaped, and then we also have the fibrinogen that has emigrated from the capillary, which then changes to fibrin. The phagocytic process is where the phagocytic cells, the neutrophils, the monocytes and the macrophages remove the debris and the necrotic tissue through ingestion and destruction. Pause the lecture again now and watch this video, which gives you a nice animation of the inflammatory process. Mentioned in the video were the cardinal signs. So we have redness, heat, swelling, pain and loss of function. We've talked in our subjective assessment lecture about how we look out for signs and symptoms within our patient. So let's think about how these relate to the inflammatory process and what's going on. So the redness and the heat is obviously caused by the increase in the blood flow to the area. The swelling is caused by that increase in the exudate, increase in the tissue fluid in the area. The pain can be caused by two things. One, we've got the increase in tissue fluid, which in turn can cause pressure on the nerve endings, which can then allow us to perceive pain. Also, because of the chemical mediators within the tissues, they too can stimulate the nociceptors, and again we can perceive pain because of that. Lastly, we may have loss of function in our patients, so as they are not able to move as freely due to the tissue damage, then they will lose their function. If we now consider the repair and healing stage, so the proliferation stage first of all, the first part of that process is where we get revascularization. So we get new blood vessels being formed, which assists with the phagocytic process. So the circulation is needed for the removal of the waste products, and also the oxygen from the blood is needed for the collagen production. This collagen synthesis and formation will be talked about in the next slides. So this is the process shown in the flow chart that the collagen formation goes through. And in the maturation and remodeling stage, we start off with type 3 collagen, which is very fine, and this becomes reabsorbed and then becomes type 1 collagen, which is much stronger. So initially we have weak and random collagen laid down, but then it matures to have more cross-links and much better tensile strength. So the remodeling stage increases the functional capabilities of the tissue, it increases the scar strength, and it helps promote an alteration of the direction of the collagen fibres. There are benefits to the acute inflammation process. First of all, the fluid exudate, although it may cause pressure, delivers nutrients and oxygen to the area that is much needed. It's possible also that the toxins will be diluted and can be disposed of through the lymphatic system, so that may have a beneficial effect on the pain. The immunoglobulins combined with and neutralise harmful pathogens. And then lastly, the fibrinogen within the exudate will initiate that fibrin formation and hence the tissue healing. There are, however, some drawbacks to the tissue healing process. What might happen is that you get collateral damage of the healthy tissue because you might get an excess of the neutrophils and lysosomal enzymes being produced, which have an effect not only on the tissue damage but also on the healthy tissue that is adjacent to that. Also, the excess fluid, as we've discussed, can cause an increase in the mechanical pressure, and that can lead to pain or compromise to the other tissues. There are many factors that affect tissue healing. So if we think about the severity of the injury, it may well be that there is more bleeding due to the severity of the injury. This might also be affected by the tissue type. We've already discussed that muscles will bleed more than ligament or tendon. So if we've got increased bleeding in the area, then the process is going to be slower. Patient's age will also affect the tissue healing process. As we get older, our tissues don't heal quite so quickly. Another important factor is movement and activity. So we need to think about when we're treating our patients, when movement is beneficial and when it isn't. So if we think back to the stages that we've talked about, in the bleeding stage, when we've got the vasodilatation taking place, the more movement we do, the more bleeding will take place, and therefore the more tissue damage there will be. So we need to control our movement within those early stages. If we think about the later stages of the healing process though, when the collagen is being laid down, what we want to do is stimulate activity so that it stretches the collagen, so that it allows the fibres to lay down in nice parallel lines, so it increases the tensile strength of the collagen fibres. So we have many interventions that we can use. We can use exercise, we can use electrotherapy, we can use mobilization techniques, we can use massage. So it's very important that we consider the effects of these techniques and what they will do at the different times of the tissue healing process, and we'll investigate that later in a tutorial. There are many types of injuries that we might come across, and these are listed here. Lastly, if we think about our physiotherapeutic aims of our treatments, within the tissue healing process, we're aiming to reduce the pain. So that pain can be caused by chemical irritation of the nerve endings or mechanical irritation of the nerve endings. So to reduce the mechanical irritation, we can try and limit and reduce the inflammatory exudate that's in the area. We can try and increase the circulation to remove the toxins and the chemical mediators such that again the pain is reduced in that area. We also want to reduce the metabolic demands of the tissue so that the healing can take place without the circulation being taken away to other areas. We need to carefully monitor the newly damaged tissue and protect it from further damage. So when we're in that bleeding stage and the early acute inflammatory stage, we need to be very careful how much movement we do and what effect we have on the tissue so that we don't promote the bleeding at this stage. When we're in the proliferative stage and the new tissue is forming, it's very weak at this point, very fragile, so therefore we need to make sure that we don't disrupt it too much at that stage. But what we do want to do is try and promote new tissue growth and fibre realignment by certain activities that we do, but again we need to carefully consider the timing. Also important with our patients is thinking about their general levels of cardiovascular and musculoskeletal fitness. So if they've got an injury in a particular area, say for example they've got a ligament injury around the knee, then we don't want them to be running on it or doing loads of weight-bearing activities, but what we might be able to get them to do is do some swimming activities where they're not actually moving the injury too much, but they're maintaining their cardiovascular fitness. We're going to be doing a tutorial later in the term where we'll look at particular case studies and consider the different stages of the tissue healing process and how those pathophysiological processes affect our choice of interventions. By this time you'll have done more about massage and exercise and using mobilization techniques, so you'll be able to consider the effects of those and how they fit in with the tissue healing process. There are some useful references for you to read here, and there are also some more useful YouTube videos that you can access within the supplementary information.